Hello everyone. Greetings from India. Greetings from Ganga Hospital, Coimbatore and our anesthesia team. Today, I will talk about regional analgesia for knee joint and below knee joint surgeries administered at the level of thigh. Before I start my presentation, I declare no conflict of interest or source of funding. Most of the images used in this presentation are my own images published in various articles and chapters. Begin with the end in the mind. Before we start, we should set our goal to determine the direction and the planning of particular strategies. Vision, mission and goal, they always stay together. Everyone has set goals, the surgeon, anesthesiologist and the patient. But they share some common goals like the surgery should be pain-free, there should be satisfactory hospital stay and it should be suitable to the ERAS protocol. What do you mean by this ERAS? ERAS is enhanced recovery after surgery. It is one of the example of pathway based perioperative care protocol. The key element of ERAS protocol includes patient education, expectation setting, aggressive optimization of comorbidities, standardized anesthetic and surgical techniques, early mobilization and discharge, early oral nutrition, and most important, the effective pain management using multimodal analgesics. So what are the requirements to achieve our set goal? We should have holistic approach. That means we should know our patient, we should know our surgeon and involved surgical steps, we should know the pain generating structures before and after surgery and their innervations, we should know the anatomy and sonoanatomy of the subsartorial region, we should able to compare our own technique with other available techniques so that we can streamline our own technique. Most of the patients undergoing total knee replacement are of geriatric age group, having multiple comorbid conditions leading to decreased functional reserve. Due to their chronic osteoarthritic problem, they cannot even perform their routine activities independently due to restricted and limited joint mobility. Overall, it leads to physical disability arising from pain and loss of functional capacity that further reduces the quality of life and increases the risk factor of further mobility. Such a patient should receive utmost perioperative care, which should encompass the best suitable analgesia options to improve the quality of life. After all, to move on is life. Mobility is life. They deserve a chance to make a choice to change their life. Give me some sunshine, give me some rain, give me another chance. I want to grow up once again. The knee is the biggest and most complicated joint of the human body that can be loaded with 7-fold body weight during walking and jumping. The joint cartilage is the most important structure of the knee joint. Damage to that will lead to pain, inflammation, limitation of range of motion that can cause bad gait pattern. In total knee replacement surgery, only these damaged cartilage surfaces are replaced by an implant that allow patient to do not only normal activity but also sports related activity after the surgery. TKR is considered as one of the most successful and life-changing surgeries where rapid recovery is possible due to improved analgesic options apart from various surgical modifications. Why it is called life-changing surgery? This was our patient, you can see, who was so much in distress, disabled and dependent on others to perform his activity of daily living. His X-ray showed a significantly deformed joint, varus on the left side and valgus on the right knee. You can see after surgery his life completely changed once the deformity got corrected. Similarly, another lady patient with severe rheumatoid arthritis affecting all joints, causing deformity and restricted mobility. So one more example of life-changing surgery. So being an anesthesiologist, we should assist them in this transition process by making their journey pain-free. For that, we need to understand the basic steps of this life-changing surgery. Total knee replacement surgery involves various steps starting from incision, extra-articular dissection and intra-articular resection. It is important to note which pain generating structures are removed and retained to plan particular procedure specific analgesic strategies. The knee joint is approached by various incisions, knowledge of which is very important for determining analgesic options. The incision is the first iatrogenic damage where tissue insults begin. Among various approaches, the medial parapatellar approach is the most common. It is also called as workhorse of the varus knee. The midline approaches are usually used for revision surgeries. Lateral approaches are sometimes needed to correct severe valgus deformity. In severe valgus deformity, chances of injury to the common peroneal nerve are most common during surgery that can lead to foot drop postoperatively. So blocks involving sciatic nerve components should be avoided in such cases. So it is always better to look for the X-ray to confirm whether you are dealing with the varus knee or valgus knee, to know whether your surgeon will take medial or lateral approach, as most of the block described for the knee analgesia may not work for other approaches. Apart from knowing surgical steps, we need to understand the post-surgical pain generation process. It is mainly due to inflammation, microfractures, tendinitis, and nerve irritations associated with surgical dissection, which causes nociceptions that stimulate free nerve endings or nociceptors present on extra-articular or intra-articular pain generators. The fast pain conducted by A delta fibers is mainly due to thermal and mechanical causes, whereas slow pain conducted by C fibers is due to chemicals like histamine, serotonin, bradykinin, prostaglandins, or substance P. Neuropathic pain is also an important component of post-surgical pain that requires separate group of drugs. One thing to remember that the pain generation process is a continuous process as pain receptors are non-adaptive unlike olfactory receptors. The pain generation is nothing but the interplay between noxious stimuli, nociceptors, and CNS. It involves conversion of continuous noxious stimulus into pain signals, then transmission of the pain signals through the pain pathways, and perception of actual pain at the central level. Thus, the pain treatment protocol should reduce the noxious stimulus by addressing causative factors like inflammation and nerve injuries. Then it should interrupt the pain pathways by blocking the transmission with the help of regional anesthesia techniques, and it should modify pain perception at the central level using various analgesic drugs mainly acting on the CNS level. We are always striving for the pain control. Have we conquered the pain? The worldwide burden of the pain has actually increased over past century. Everybody wants happiness and nobody wants pain. But you can't have a rainbow without little rain. Attitude always matter while feeling the pain, dealing with the pain or healing the pain. When patient feels pain, it is a passive acceptance in negative situation. While dealing with the pain, it should be positive attitude in negative situation. ABCD of the pain management is very essential, which includes assessment of the pain using pain scale, believing in the patient complaints, choosing appropriate pain control options, delivering them in logical manner, and empowering or enabling the patient in their own pain management process. Before deciding the strategy for pain management, we need to understand its evolution. The strategies of the pain management has been evolving from the era where pain was underrated, which was called as oligoanalgesia, with relatively less use of opioid due to the fear of its side effects. It's the era of opioid phobia. Then transition to the era where opioids were used in huge quantities in various forms due to aggressive marketing of pharma companies. After the addition of new concepts like multimodal analgesia, inclusion of regional analgesia as an adjunct to multimodal analgesia, preemptive analgesia, local infiltration analgesia, the pendulum has begun to swing from opioid sparing techniques to the era of opioid free analgesia. Based on the recent trend, a non-profit organization like Society of Opioid-Free Analgesia (SOFA) was formed to research, promote and educate anesthesia professionals and the general public on opioid-free pain management techniques. If you go to their website goopioidfree.com, you can find lot of protocols promoting opioid-free anesthesia. In this picture, if you see, the stethoscope is completely replaced by the ultrasound probe. So we are living in the era which is era of a procedure specific anesthesia technique, precision type of regional analgesia technique, where researchers will likely focus more on the detailing of the innervation and achieving more target specific block. In this particular decade, new technique will probably be introduced to replace existing conventional blocks. So what is the ideal strategy to combat pain? It is multimodal analgesia for multifactorial pain. A combination of various pharmacological agents, non-pharmacological techniques and regional analgesia techniques constitute the concept of multimodal analgesia. The components of multimodal analgesia acts on various levels of the pain pathway. It includes different categories of the drugs given by different routes of administration having different mechanism of actions causing decreased side effect of each category. It has to follow WHO principle, that is by the clock, by the patient, by appropriate route and by the ladder. So what are the consequences of unrelieved pain? Unaddressed post-surgical pain, it initiates several neuroendocrine stress response, leading to secretion of various hormones, stress hormones like ACTH, cortisol, catecholamines, ADH that result in increase in blood pressure, heart rate, prolonged recovery and infection. It is important to block the process of acute pain becoming the chronic pain, as acute pain can be treated properly, but it is very difficult to treat the chronic pain. Preemptive analgesia should be the component of multimodal analgesia as it plays a major role in perioperative pain management by inhibiting central and peripheral sensitization. So far we covered patient profile, surgical steps, pain generators, pain management strategies. Now we will try to understand the role of regional analgesia as an adjunct to the multimodal analgesia. What is procedure specific regional analgesia? How identify, select and combine approach helps to simplify things, and what are the available regional analgesia techniques and their comparisons. Many times people ask me if we have given effective block or any regional analgesia technique, why there is need for other drugs. For that I just created one scenario. Suppose you are there inside the OT and outside the OT in the corridor there is a fire. So how will you protect yourself? So you have only one access door to the fire and you cannot go out from any other way. So how will you protect yourself? So first of all, you will call for help. Then you will try to avoid the spread of the fire inside the operation theater. So for that you will close the door so that the fumes or the smoke will not enter inside the OT. Then you will try to protect yourself by making yourself wet with the available fluids inside the operation theater. And finally, you will just wait and watch till the fire gets extinguished and the way gets clear. Similarly, here the fire is nothing but the surgical inflammation at the surgical site, and regional analgesia technique is just the door what you have closed. It is just the blocking the pain pathway from the surgical inflammation area towards the brain. Now here you have call for help. The different modalities of the drugs, actual anti-inflammatory drugs including paracetamol, NSAIDs, anti-neuropathic pain, those are actual drugs which will actually treat the surgical inflammation. And protecting yourself means prescribing some drugs which are not only acting peripherally over the surgical inflammation area but also centrally to protect the brain. So regional analgesia is just for blocking the pain pathway. It is not the treatment of the actual cause of pain, that is surgical inflammation. Identify, select and combine approach includes identification of the target innervation as per the procedure, then selecting the target blocks which will include all the identified target innervation, and finally combining all selected target blocks to provide complete procedure specific analgesia. First of all, we'll try to identify the target innervation of the knee joint surgery. Knee joint basically supplied by the lumbar plexus anteriorly and sacral plexus posteriorly through their cutaneous branches supplying skin, muscular branches supplying muscles, and osteotomal branches supplying bone. Before supplying the knee joint, these nerves forms three different plexuses. Subsartorial plexus lying on the medial side under the sartorius in the adductor canal region supplying anteromedial knee and anterior joint capsule. Peripatellar plexus lie around the patella anteriorly. It supplies skin around the patella and anterior joint capsule. And popliteal plexus, it lies posteriorly. It supplies all intra-articular structures below the anterior capsule and the posterior capsule. Important innervation of the anterior knee include nerve to vasti, and then saphenous nerve coming on the medial side, which gives the infrapatellar branch over the inferior-medial aspect of the knee joint. Then the inferior-medial genicular nerve, which is a branch of tibial nerve supplying the inferior-medial aspect of the knee joint. Then one branch coming out from the common peroneal nerve supplying the superolateral aspect of the knee joint. And then one reflex branch coming out from the common peroneal nerve supplying the inferolateral aspect of the knee joint. The posterior knee is innervated by the articular branches coming out from the sciatic nerve, tibial nerve and common peroneal nerve. These articular branches form a popliteal plexus along with the contribution of the posterior division of obturator nerve, which supplies all intra-articular structures of the knee joint below anterior capsule and posterior capsule. Knowledge of the complex innervation of the knee joint is very essential to select particular procedure specific regional analgesia technique. That includes innervation of the dermatomes, osteotomes and myotomes of the knee joint. If you see it here, many people think that saphenous nerve is only having the cutaneous supply. As seen here is the inferior medial aspect of the knee joint and posterior medial aspect of the knee joint. But when the saphenous nerve is inside the adductor canal, it gives one muscular branch to the sartorius, as well as it is also having osteotomal innervation over the anterior part of the lower femur and medial part of the upper tibia. So it is a sensory nerve but not just a cutaneous nerve. So along with the dermatomal and osteotomal innervation, you should also have a knowledge of richly innervated anterior capsule of the knee joint and posterior capsule of the knee joint to formulate any procedure specific regional analgesia strategy. The area below the knee joint is not as complexly innervated as that of a knee joint. It is contributed by the branches coming out from the common peroneal nerve and the tibial nerve with the minor contribution from the saphenous nerve. Saphenous nerve, if you see it here, it supplies the skin over the medial aspect of the leg, as well as it is having osteotomal innervation over the proximal medial tibia as well as medial malleolus. So whole innervation of the leg below the knee joint comes from common peroneal nerve, tibial nerve, which are the component of the sciatic nerve, and saphenous nerve. After identifying the target innervation, now we will select the target blocks. So what are the regional analgesia options available for the knee surgery from center to periphery? It includes neuraxial blocks that involves spinal anesthesia, epidural anesthesia and combined spinal epidural analgesia. Then plexus block, lumbosacral plexus block. Then individual nerve blocks, femoral nerve blocks, obturator nerve blocks and sciatic nerve blocks. Then selective tibial nerve blocks. Then subsartorial blocks that includes femoral triangle block, adductor canal block and dual subsartorial block, and the peripheral most infiltration technique like local infiltration analgesia or infiltration between popliteal artery and capsule of the knee joint, that is IPAC block. And there are some high volume blocks described like a 4-in-1 block given in the distal adductor canal and high pack block, that is high volume proximal adductor canal block given in the proximal adductor canal. So if you see it here, up to this individual nerve blocks, these are considered as non-motor sparing techniques because of the involvement of the muscle weakness. So this from this green circle onwards, all the blocks like these subsartorial blocks, they are considered, including the peripheral blocks, they are considered as a motor sparing blocks. All these motor sparing blocks are described for the knee surgery except for HIPAC block, CAPS block, 4-in-1 block. Those are described for the below knee surgeries. So before planning any particular regional analgesia technique, we need to understand the purpose of each block, whether they are effective for anterior knee pain or posterior knee pain or both. So for total knee replacement surgery, the innervations of the structures causing anterior or extra-articular pain can be blocked by subsartorial block, whereas the intra-articular pain can be blocked by posterior component block. So to provide complete and effective procedure-specific analgesia, both the components, anterior and posterior components, needs to be blocked. Among individual nerve block, the femoral nerve block provides excellent pain relief but associated with quadriceps weakness that can delay ambulation and increase risk of fall. Similarly, the sciatic nerve block is associated with hamstring weakness, and obturator nerve blocks is associated with adductor weakness that can cause risk of fall and delay ambulation. However, the peripheral branches, which are usually the sensory branches, the anterior division and posterior division of the obturator nerve, that can get blocked in various subsartorial blocks. Since all the selected blocks are given at the level of the thigh, so understanding of these blocks depends on the anatomical knowledge of two prominent landmarks in the thigh, that is femoral triangle and adductor canal. As you know that the femoral triangle, the base is formed by the inguinal ligament, whereas the medial border is formed by the medial border of adductor longus and lateral border is formed by the medial border of sartorius. If you see in this figure, you can see two intersection points A and B. The point A is the intersection point of medial border of sartorius and lateral border of adductor longus. It is nothing but the apex of the iliopectineal fossa, which is the proximal subset of the femoral triangle, whereas the B is the intersection point of the medial border of the adductor longus and medial border of the sartorius. It is nothing but the apex of the femoral triangle. So apex of the femoral triangle, it is the intersection points of the medial border of the sartorius and medial border of the adductor longus. So it is just a demarcating point. From above the apex, the area will be femoral triangle, and below the apex, that area will be the adductor canal. So this femoral triangle and adductor canal are just like a tunnels and funnels. So femoral triangle one funnel is connected to the musculoaponeurotic tunnel of the adductor canal, which can lead to popliteal fossa through the adductor hiatus, which is nothing but the another two funnels. Adductor canal is the musculoaponeurotic tunnel in the middle third of the thigh. It extends from the apex of the femoral triangle above to the adductor hiatus below. It is triangular in cross section, bounded anterolaterally by the vastus medialis muscle and posteromedially by the adductor longus muscle proximally and adductor magnus muscle distally. Medially, it is bounded by vasoadductor membrane, which is a strong fibrous membrane joining anterior and posterior wall, whereas the sartorius forms the roof of the adductor canal. In between vasoadductor membrane and sartorius, there is a sandwich subsartorial plexus, which is formed by the saphenous nerve, medial cutaneous nerve of the thigh, and anterior division of the obturator nerve. If you see it here, the nerve to vastus medialis is not the content of the adductor canal. It lies between the intermuscular plane of sartorius and vastus medialis, and it lies outside the adductor canal above the vasoadductor membrane, whereas saphenous nerve lies inside the adductor canal. The vasoadductor membrane is also called as medial intermuscular septum. It is nothing but the fibrous connective tissue forming the medial border of adductor canal. This is a schematic representation of the adductor canal, which is a triangular in cross section. So basically, adductor canal is having three foramina: superior foramina, inferior foramina, and anterior foramina. Because of the three different events taking place in the adductor canal, it is divided into proximal, mid, and distal adductor canal. Through the superior foramina, this femoral vessels enters along with the saphenous nerve inside the adductor canal. Through the anterior foramina, the saphenous nerve exits by piercing vasoadductor membrane along with the descending genicular vessels, which are the branches of femoral vessels. And later on, through the inferior foramina, the femoral vessel exits and continues as a popliteal vessel through the same inferior foramina, which is nothing but the adductor hiatus. The posterior division of the obturator nerve also enters, and it forms or it contributes in the formation of the popliteal plexus in the posterior knee. If you see it here, nerve to vastus medialis, it never enters inside the adductor canal. It always lies above the vasoadductor membrane. Apart from the anatomy of the thigh, it is also important to know the zona anatomy of the thigh at various levels, especially identifying the apex of the femoral triangle, which will decide the territories of femoral triangle and adductor canal. As shown in the figure C, the apex of the femoral triangle can be identified where medial border of the sartorius and adductor longus overlies, forming a sign of 3, also called as kissing sign. So region above the apex of the femoral triangle is the femoral triangle area, and below is the adductor canal area. The saphenous nerve is actually nothing but the continuation of the posterior division of the femoral nerve that crosses the thigh from anterior to the medial aspect and travel from deeper to the superficial plane. The presence of vasoadductor membrane is the peculiarity of the adductor canal region. Due to presence of vasoadductor membrane, the lower border of the sartorius appears bilayer in the adductor canal region. So we'll see the first subsartorial block, that is femoral triangle block. So to avoid motor blockade due to involvement of the femoral nerve, the femoral triangle block is given in the distal most part of the femoral triangle, mainly targeting the saphenous nerve under the sartorius. It covers the anteromedial innervation of the knee joint. For femoral triangle block, you need to first identify the apex of the femoral triangle by seeing the sign of 3 or the kissing sign, and move probe around 1 to 2 centimeter proximal to the apex of the femoral triangle, so that you will enter into your target area, that is distal femoral triangle area. In that, as per the described technique, you have to focus on the saphenous nerve which lies lateral to the femoral vessels. Previously, even when I was a fellow 10 years back, the adductor canal block was performed by keeping the probe over the mid-thigh location, seeing the femoral artery exactly in the midpoint of the sartorius, and injecting local anesthetic around the saphenous nerve lying on the lateral side of the artery, sometimes creating a horseshoe-shaped spread. Later in 2017, Wong et al. Tried to define the exact location of adductor canal using an ultrasound and by locating the apex of the femoral triangle as the beginning of adductor canal. What they did, they found the mid-thigh location, like a red arrow, that always lie proximal to the apex of the femoral triangle. This is a blue arrow which is the apex of the femoral triangle. So the mid-thigh adductor canal block was nothing but the femoral triangle block, since the apex determines the extent of the femoral triangle from where the adductor canal is starting, and the mid-thigh point is actually coming proximal to the apex of the femoral triangle. So that area is nothing but the femoral triangle area. So the block in that particular area is nothing but the femoral triangle block. Various dye studies in subsequent years demonstrated the spread of the dye in the popliteal area when injected into the adductor canal below the vasoadductor membrane, whereas the dye injected in the femoral triangle remained under the sartorius and never reached the popliteal region. Due to varied neurovascular relationship, the adductor canal can be divided into three parts: proximal adductor canal, which is just distal to the apex of the femoral triangle, where the adductor longus is also seen, magnus is also seen. Then mid adductor canal, where the descending genicular artery and the saphenous nerves comes out by piercing the vasoadductor membrane, and adductor longus is replaced by the adductor magnus muscle. And the distal adductor canal, where the femoral vessels moves away from the sartorius and dips into the adductor hiatus to become popliteal vessels. So no nerves lie in the mid and distal adductor canal in the adductor canal area. So we can see the saphenous nerve between the sartorius and gracilis muscle in the subcutaneous plane in the distalmost part of the adductor canal. If you see it here, you will see one complete thali, or it is called complete meal, where you can see individual recipes inside the meal. So this individual recipe, if you moved out or if you take out, it will have its own identity. So these individual recipes may be proteins, vegetables, grains, dairy products, and this each individual recipe is actually made up of different ingredients which are mixed in specific quantity and concentration to make one complete recipe. So different ingredients, when combined together, they form a one recipe, and when one recipe like other recipe mixed together, they form a complete thali or meal. Similarly, the procedure specific block is actually combinations of the target blocks like recipes, which having different ingredients like a target nerves or individual nerve blocks, which completely form one complete procedure specific regional analgesia technique. Dual subsartorial block, or DSB, was designed by our team in 2017 and described as a procedure specific and motor sparing regional analgesia technique for total knee replacement surgery with medial approaches only. It is a type of precision region analgesia as it targets specific innervations. It is also a hybrid form of block involving combination of two subsartorial blocks. Due to its extensive coverage, we believe that it is a procedure specific. Based on our clinical findings, statistical analysis and anatomical correlation, we believe that it's a motor sparing block, and due to effective analgesia provided by DSB, it can be described as an opioid reducing or opioid sparing block. It provides effective postoperative analgesia if used as an adjunct to multimodal analgesia to TKR surgeries with medial approaches. In DSB, two injections at two different locations are given under the sartorius. It is given immediately after the surgery by placing the high frequency probe horizontally over the anteromedial aspect of the thigh. First step is to identify the apex of the femoral triangle by seeing the sign of 3. The probe is then moved 1 to 2 cm proximal to the apex into the distal femoral triangle area, where 10 to 20 ml of local anesthetic solution is injected, separating the intermuscular plane between the vastus medialis and the sartorius and directly targeting nerve to vastus medialis and saphenous nerve. For the second injection, the probe is kept 1 to 2 cm distal to the apex of the femoral triangle into the proximal adductor canal area, where again 10 to 20 ml of the local anesthetic solution is injected just next to the femoral artery but under the vasoadductor membrane. Sometimes you can see the compression of the femoral artery during injection and disappearing spread of the drug. Though the effect of this injection will be same in all level of adductor canal, we recommend giving this block mainly in the proximal adductor canal to avoid proximity to the sterile surgical field. The first injection of the dual subsartorial block directly involved nerve to vastus medialis and saphenous nerve. It also involves subsartorial plexus, which is sandwiched between the vasoadductor membrane and the sartorius in the adductor canal region through the distal spread of the drug, and it also involves the medial half of the peripatellar plexus due to the proximal spread into the femoral triangle. Whereas the second injection of the dual subsartorial block directly involves saphenous nerve, and it involves popliteal plexus through the distal spread into the popliteal fossa. So second injection is mainly given to cover the posterior component of the knee pain, and first injection is mainly given to cover the anterior component of the knee pain. Local infiltration analgesia or LIA is the widely practiced infiltration technique by most of the orthoplasty surgeons using different cocktail regimen involving local anesthetics and other adjunct drugs. So thus its efficacy depends on different types and volumes of the local anesthetic used combined with other types of the drugs and also various sites chosen by the surgeon. The problem with the LIA is the duration of analgesia, which is not more than 12 hours, causing severe breakthrough pain. Secondly, chances of infection is more common in LIA categories. Also, some of the agents of the LIA having tendency of chondrotoxicity which may cause joint loosening and chances of redo surgeries in the long-term follow-ups. IPAC is nothing but the infiltration between popliteal artery and the capsule of the knee joint. It creates a field block in the region between the popliteal artery and the knee joint where articular branches crosses. It mainly targets the popliteal plexus, thus it works for the posterior knee pain. It can be given by keeping the probe anteromedially to the thigh or posteriorly in the popliteal region. So it can be given using two approaches, medial approaches or popliteal approach. These blocks needs to be given preoperatively due to loss of anatomical landmark after surgery. Ultrasound guided genicular nerve block mainly targets the genicular nerve arising from the tibial nerve, femoral nerve, common peroneal nerve or obturator nerve that supplies anterior and posterior capsule of the knee joint. This block is mainly described to provide analgesia as a chronic pain procedure, but its role to provide postoperative analgesia is doubtful since during surgery the richly innervated anterior capsule is excised and the posterior capsule is not even touched by the surgeon. So the pain generation process of the anterior component or anterior capsule is negligible since that whole pain generator is removed and posterior capsule is not touched, so that area is also not painful, relatively not painful. For bilateral total knee replacement surgery, either staged or single stage, patient selection is very important. It's very crucial as it is associated with increased risk of cardiac complications, pulmonary embolism and increased blood transfusion. The choice of regional analgesia technique mostly will be combined spinal epidural analgesia plus bilateral peripheral nerve blocks along with local infiltration analgesia bilaterally, provided that the maximum allowable dose, toxic dose of the local anesthetic should be calculated properly and it should not cross that particular limit. Knee arthroscopic surgery is actually minimal invasive type of surgery that involves meniscal repair, loose body removal surgeries, ACL, PCL, MCL surgeries. The duration of such surgeries are shorter, less than 1 to 2 hours. And regional analgesia option for such surgery include adductor canal block, IPAC block or intra-articular local anesthetic infiltration using some cocktail regimens also, and hamstring block. Hamstring block was described in 2012 mainly to cover the hamstring graft harvesting site. Around 30 to 40 local anesthetic solution was used and a series of injection is usually given that involves 5 to 7 ml of the drug subsartorial area under the sartorius and around 5 to 7 ml of the drug below the gracilis and around 10 to 15 ml of the drug around the semitendinosus muscle. When one thinks of a problem, there is always a solution. Associated challenges in knee surgeries can be overcome by proper selection of patient, optimizing comorbidities, proper planning, following protocols and guidelines, and considering priorities and goals. Consideration of the regional analgesia for below knee surgeries is always a debatable topic because of the false belief that it can mask the symptoms and delay the diagnosis and treatment of the acute compartmental syndrome. So there is always a dilemma situation to give or not to give. So regional analgesia is actually reducing the opioid consumption and it facilitates enhanced recovery, early mobility and discharge. But because of the chances of development of the compartment syndrome, especially in the high risk surgery, and because of the belief that it can mask the symptoms of the developing compartmental syndrome, there is always a reluctancy of the surgical team to consider the regional analgesia for below knee surgery. Also, there is lack of evidence supporting the safety of the regional analgesia for the below knee surgery. So even the development of the acute compartment syndrome can be inevitable under favorable circumstances, regardless the presence or the absence of the regional analgesia. Therefore, a mere fear of the preventable and treatable condition like acute compartment syndrome should not deprive the patient of their right to remain pain-free with effective and complete post-operative pain management protocols. The ideal regional analgesia technique for below knee surgery should provide effective analgesia without masking the symptoms of the developing compartment syndrome, and it should facilitate early mobilization and discharge. So available techniques includes epidural infusion, femoral and sciatic nerve blocks, especially higher blocks are given for anesthesia purpose when the tourniquets are applied above the knee joint. Then comes to the distal blocks like popliteal sciatic and saphenous nerve blocks. Then we have the modified lateral popliteal sciatic block, which we call as crosswise approach to the popliteal sciatic block, which is called as CAPS block. Then 4-in-1 block, which is the high volume block. It is a motor sparing block, completely procedure specific. Like HIPAC block is also motor sparing and procedure specific block for below knee surgeries. CAPS block is nothing but the crosswise approach to the popliteal sciatic block. It is a modified lateral popliteal sciatic block. Here the probe is kept over the lateral aspect of the thigh and sciatic nerve is targeted from the lateral aspect of the thigh in supine position of the patient. So for this block, the positioning of the patient is not required. The sonoanatomy of this block can be obtained in 3 simple steps. Just keep the probe over the lateral aspect of the thigh. Try to see the hyperechoic femur along with the hypoechoic muscle above it, which is the vastus lateralis muscle. Then try to move the probe little posteriorly and try to see another hypoechoic muscle, which is the bicep femoris muscle next to the vastus lateralis muscle. Now, by maneuvering the probe, try to clear or make the lower border of the bicep femoris prominent and clear so that this hyperechoic sciatic nerve will appear just below the border of the bicep femoris. So upon tracing the probe proximal and distal, you can see the bifurcation of the sciatic nerve into tibial and common peroneal nerve. So ideal injection should be given before the bifurcation of the sciatic nerve. HIPAC block is high volume proximal adductor canal block, where around 30 to 40 ml of diluted local anesthetic solution is injected in the proximal adductor canal area. This block targets saphenous nerve directly and sciatic nerve indirectly due to the posterior spread into the popliteal fossa. For this reason, it is also called as anterior indirect approach to the popliteal sciatic nerve block. It covers all the innervation of the leg below the knee joint. Due to diluted local anesthetic used in this block, it may not mask the symptoms of the compartment syndrome. So, HIPAC block is based on the concept that any drug injected into the adductor canal below the vasoadductor membrane will reach to the popliteal fossa. So, this is adductor canal and this is popliteal fossa. The saphenous nerve entering into the adductor canal through the superior foramina and it leaves the adductor canal through the anterior foramina. So this is the posterior division of obturator nerve which directly enters into the adductor hiatus and it enters into the popliteal fossa. So once it enters into the adductor hiatus into the popliteal fossa, it gives articular branches which contributes in the formation of the popliteal plexus, which is also contributed by the articular branches coming out from the sciatic nerve, tibial nerve and common peroneal nerve. So sciatic nerve, tibial nerve, common peroneal nerve along with the posterior division of obturator nerve, their articular branches form the popliteal plexus which actually supply the posterior knee. So any drug injected here, upon increasing the volume, it will start first involving the saphenous nerve directly. Then in the adductor hiatus, it will involve the posterior division of obturator nerve. Then it will start involving the popliteal plexus with the 10 to 20 cc of the drug. Popliteal plexus is involved Upon increasing the volume, it will start involving the mother branches like tibial nerve and common peroneal nerve. Upon further increasing the volume, it will start involving the sciatic nerve. So around 30 to 40 ml of the drug is required to involve the sciatic nerve into the popliteal fossa. Hypac block is different from the conventional proximal adductor canal block because of its site, because of the local anesthetic used, because of the concentration of the local anesthetic and volume of the local anesthetic used, and also because of the timing of the block. This block is having particular timing. It has to be given only after regaining of the motor movements, especially the toe movements in the post-operative period, before the pain starts. So it is given in 5 steps. First, assess whether toe movement has come back or not. Then identify the apex of the femoral triangle. Then locate the proximal adductor canal area. Then inject around diluted 30 to 40 ml of local anesthetic solution along with the dexamethasone. Recommended solution is 0.1 ropivacaine. And after injection, reassess the motor involvement. Ideally, there should not be any motor involvement. Patient should keep on moving the toes, or whole motor movement should come back. So as per our study, it provides excellent analgesia up to 48 hours in the post-operative period when used as an adjunct to the multimodal analgesia. Similar concept, but in distal adductor canal, was described by Dr. Ritesh Roy in his radio contrast dye study, where he found the dye injected into the distal adductor canal area spreads over the popliteal fossa to involve the sciatic nerve. So on the basis of his concept, he described two blocks, 4-in-1 block and modified 4-in-1 block. Unlike Hypac block, which is given into the proximal adductor canal, the 4-in-1 block is given into the distal adductor canal. The important identification landmark for this block is descending genicular artery, whereas the identification landmark for Hypac block is the apex of the femoral triangle. The volume of the local anesthetic required is around 30 to 40 ml of 0.2 ropivacaine. It is described to provide analgesia for knee surgery as well as below knee surgery. To cover the sparing of the nerve to vastus medialis, which lies above the vasoadductor membrane, Ritesh Roy sir has described modified 4-in-1 block in which one injection is given above the vasoadductor membrane and second injection is below the vasoadductor membrane. So it involves two injections. First injection above the vasoadductor membrane around the nerve to vastus medialis, and second injection below the vasoadductor membrane perivascularly. Among various available regional analgesia options for knee surgeries and below knee surgeries, the goal is to choose motor sparing, opioid sparing, and procedure specific modalities. For that, we should know all the approaches of various types of knee joint surgeries along with their innervations. And we also should know about the pain generators before and after surgery to plan for procedure specific regional analgesia technique. Any surgery is correction of existing pathology and creation of iatrogenic pathology, that is surgical dissection. This is a schematic representation of the knee joint where the C shapes you can see intra-articularly. These are meniscus, then cruciates also visible in the form of X alphabet. Then these are the anterior capsule, anterior musculature, posterior musculature, and this anterior skin and subcutaneous tissue, posterior skin and subcutaneous tissue. Similarly, this area colored by the yellow color is actually anterior innervation, whereas the blue color represent the posterior innervation. So if you see, the posterior innervation also include the intra-articular component along with the posterior capsule. So if you consider the pre-operative total knee replacement knee joint, so pre-operatively such patient is having more pain inside the knee joint because of the pathology involving the articular cartilage, that is osteoarthritis of the knee joint, whereas the extra-articular component, the pain generation is relatively less. When the same patient undergoes total knee replacement surgery, all the intra-articular pain generators are excised and replaced by the non-neural and non-vascular metallic implant, where the richly innervated anterior capsule is also getting excised. So whatever the pain generation which was there before during the surgery, it is getting removed. So most of the pain generation will happen into the surgical dissection area which was relatively healthy before the surgery. So most of the time the post-operative pain generation of the anterior component is more than the posterior component. Similarly, for orthoscopic surgery, if you see, the involved pathology is intra-articular, so the pain before surgery is intra-articular. Even after surgery, the whole surgical dissection takes place intra-articularly. The pain generation will remain inside the knee joint. Whereas extra-articular surgical dissection, which is nothing but the port insertion side, the pain generation from that side is negligible. So block involving mainly the posterior component should be given priorities for the orthoscopic knee surgeries. Most importantly, we should know the analgesic coverage of each regional analgesia option to use them as per analgesic requirement. In first figure, femoral triangle block will involve the saphenous nerve and nerve to vastus medalis. So it will cover the anterior medial aspect of the knee joint, but it will not cover intra-articular component of the knee joint. Adductor canal block, by covering the saphenous nerve directly, it will cover saphenous nerve territory, as well as by distal spread into the popliteal plexus, it covers the intra-articular component. Dual subarterial block covers anterior medial knee by its first injection, and second injection covers the intra-articular component of the knee pain. So it is having procedure specific coverage for the medial approaches of the total knee replacement surgery. IPAC blocks mainly targets the popliteal plexus, so it will cover only the intra-articular pain. Local infiltration analgesia is having wide coverage, but its coverage depends on the surgeon choice of specific sites of injection. And also the duration of the analgesia is the problem with the local infiltration analgesia, which is not more than 12 to 18 hours. High pack block covers all the innervation below the knee joint, so it involves the sciatic nerve component as well as femoral nerve components. Postoperative assessment of any planned block is very important at regular interval to look for any chances of the sparing so that it can be rectified during the next time. It is also important to determine the rescue analgesia protocol as per the pain location in the postoperative period. To conclude, femoral triangle block mainly covers the anterior knee pain, whereas adductor canal block, because of the coverage in the popliteal plexus, it covers posterior knee pain than anterior knee pain. Dual subsartorial block is described as a procedure specific block for total knee replacement surgery with the medial approaches that covers both anterior and posterior component of the knee pain. IPAC block, by covering the popliteal plexus, can be useful for the posterior knee pain. HIPAC block and 4-in-1 block, these are described as a procedure specific and motor sparing block for below knee surgery, as they cover all the innervation below the knee joint by blocking sciatic nerve and saphenous nerve. The motor sparing effect of the CAPS blocks depends on the concentration of the local anesthetic used. The efficacy of the local infiltration analgesia depends on the various sites of the administration by the surgeon. Also, the duration of analgesia is always a problem. It is not more than 12 to 18 hours, so there is always chance of breakthrough pain, and it is also associated with infection, chondrotoxicity, and redo surgeries. So basically, we just need to maintain the balance between mobility and pain control by providing excellent analgesia. It is my privilege to describe some of the block from my own country, made in India block, like dual subsartorial block, HIPAC block, 4-in-1 block, modified 4-in-1 block, CAPS block. Comparison of each block is given in my Twitter account. Now I will play one video for describing the complete Sona anatomy of the anterior thigh.
All the blocks at the level of the thigh, usually only higher frequency linear probe can be used. So first of all, we'll try to scan from the femoral triangle area up to the adductor canal area. So femoral triangle can start from the inguinal crease. So we will just trace first vascular structure, and then we'll try to identify each muscle. So right now I am over the inguinal crease, like routine femoral nerve block we are giving. Just I am tracing the femoral artery till I can trace it up to the adductor canal area. So now I am tracing femoral artery. I can see some variations in the muscles around the femoral artery. Still artery in the picture. And I can see the femoral artery going away and dipping down somewhere in the opening in the muscle. Now, after seeing the course of the femoral artery, we will try to identify the muscle around the femoral artery. So we'll start with the femoral crease or inguinal crease. My orientation marker is towards me. The position of leg is little externally rotated. Now I am keeping probe over the inguinal crease. I can see the compressibility of the femoral vein and femoral artery. On the lateral side of the femoral artery, you can see the hypoechoic iliacus muscle, which is quite big muscle, and femoral nerve gets sandwiched between the iliacus muscle and the femoral artery. You can see the femoral nerve. This is a hyperechoic femoral nerve at the level of inguinal crease. Further laterally, if you go, you can see the triangular sartorius which will come into the picture. So this side is the iliacus, on the medial side, lateral side is the sartorius, and below sartorius there is one more hypoechoic small muscle which is nothing but the rectus femoris muscle. Now if you see, we'll trace the sartorius and we'll see how it is related with the femoral artery. So now I am tracing sartorius downwards. So now it is going near to the femoral artery. Further tracing distally, I can see the femoral artery is traveling from the one end of the sartorius to the other end of the sartorius. Okay. Then we further keeping the probe over the inguinal crease. We go further medially. First, you can see the femoral vein. Then we can see the loop-like muscle, which is nothing but the pectineus muscle. Then further medially, if we go, now my probe is on the medial aspect of the thigh over the inguinal crease. You can see three muscles, which is adductor longus, adductor brevis, and adductor magnus. So three muscles in between, you can see the hyperechoic anterior division of obturator nerve and posterior division of obturator nerve. Now we'll see the uppermost muscle, the hypoechoic adductor longus muscle. We'll try to trace that muscle distally, and we'll see its relationship with the artery. Now the same adductor longus, we are tracing it down. You can see that adductor longus is meeting the artery at one particular junction. So now we have identified the sartorius above the artery, and we have identified adductor longus, which is on the medial aspect of the artery. Further, on the inguinal crease, if you keep the probe, we have seen the rectus femoris muscle below the sartorius. If you see the same rectus femoris muscle, if you trace rectus femoris muscle further down over the anterior aspect of the thigh, you can see the femur is appearing. And there are two muscles. Above one is the rectus femoris muscle. And since I am over the anterior aspect of the thigh, the lower muscle is a vastus intermedialis muscle. So if you move further medially, you can see the vastus intermedialis. Then vastus intermedialis is getting interrupted, and there is a continuation of vastus medialis muscle. The whole muscle next to the femur is a vastus medialis muscle. And if you move further medially, you can see the vastus medialis is again meeting the femoral artery. So now we have identified all the muscles around the femoral artery in the region of the thigh. Now we will try to find out what is the apex of the femoral triangle. So now, if I keep my probe moving down, distally, I can see the sartorius muscle is coming next to the sartorius muscle over the posteromedial aspect. We have identified that muscle as a adductor longus muscle, and over the anterolaterally, we have identified that big muscle is a vastus medialis muscle. So now, we can see the sartorius and adductor longus movement together. If you move further distally, the sartorius and adductor longus muscle, they are lying over one another. They are overlying each other. So this portion, this point, and this sartorius muscle, this is the medial border of the sartorius muscle, and this is the medial border of adductor longus muscle. They are lying over each other. They form, this is nothing but the apex of the femoral triangle. They form sign of 3. This is also called as sign of 3 because it appears like a sign of 3. And it is also called as kissing sign. So this is the distalmost extent of the femoral triangle. Below that, any area under the sartorius will be the adductor canal area. So we have identified femoral triangle, apex of the femoral triangle. So area, suppose we mark that area, apex of the femoral triangle at one particular point. So apex of the femoral triangle we have marked. So this line corresponds to the apex of the femoral triangle. Now usually, previously people used to put the probe over the mid-thigh, and by seeing the location of the femoral artery exactly in the center of the sartorius. Now if you see, my probe is exactly over the mid-thigh, and I can see the artery exactly in the center of the sartorius. And I can see the hyperechoic saphenous nerve just lateral to the femoral artery. But if you see clearly, this is the mid-thigh point. I have marked that mid-thigh point also. So this is mid-thigh point, and this is apex. So as per the studies, we confirm that mid-thigh point always lies proximal to the apex of the femoral triangle. So area above the mid-thigh, so area at the level of the mid-thigh is nothing but the femoral triangle area. Now again we'll identify the apex of the femoral triangle. Then we move further distally. We can see the adductor longus muscle is disappearing, and it is replaced by another muscle. That another muscle is nothing but the adductor magnus muscle. Now you can see carefully the branching out of this femoral artery. If you see it, adductor longus is replaced by the adductor magnus. So when it is replaced by the adductor magnus, up to that point, from the femoral apex of the femoral triangle is nothing but the proximal adductor canal area. Then when it is replaced by the adductor magnus, you can see one branching coming out from the femoral artery. That branching is nothing but the descending genicular artery. So when the descending genicular artery is appearing and adductor longus muscle is replaced by the adductor magnus, that means you are into the mid adductor canal portion. So you can see typically after the apex of the femoral triangle, if you clearly identify, you can see if you move upwards into the femoral triangle and if you see the lower border of the sartorius, and then if you move distally to the apex of the femoral triangle and if you see the lower border of the sartorius, you can typically see the bilayering of the sartorius because of the presence of vasoadductor membrane. So now, so far we have identified the proximal adductor canal area, mid adductor canal area. Now, the artery will move away from the sartorius and will dip into the opening of the adductor magnus. So this area is nothing but the distal adductor canal area, where it becomes popliteal vessel. Now we'll see all the blocks one by one. So far we have identified apex of the femoral triangle. We have marked the apex of the femoral triangle where it forms the kissing sign or sign of 3. Now you just move 1 to 2 centimeter above the apex of the femoral triangle. You will enter into the distal femoral triangle area. Now try to see the intermuscular plane between the sartorius and vastus medialis muscle. You can see 2 hyperechoic dots in between the intermuscular plane. These dots are nothing but the saphenous nerve, just lateral to the femoral artery, and nerve to vastus medialis, which is further lateral to the saphenous nerve. So femoral triangle block can be given by separating this intermuscular plane and by putting the needle in plane direction from lateral to the medial side and separating the plane with the 10 to 20 ml of the drug. So again, coming towards the apex of the femoral triangle, if you move 1 to 2 centimeter distal to the apex of the femoral triangle, you will enter into the proximal adductor canal area. So the proximal adductor canal block can be given just 1 to 2 centimeter distal to the apex of the femoral triangle. This is apex, 1 to 2 centimeter distal. This is the proximal adductor canal area. Here, you have to deposit around 10 to 20 cc of the drug under the VAM. As per the diastole, the whole drug will track along with the femoral vessel and it will move towards the popliteal area and it will stain the popliteal plexus. So dual subsartorial block, again, we are identifying the apex of the femoral triangle. We are moving 1 centimeter upwards. We are identifying the saphenous nerve, now to vastus medialis, and specifically targeting those 2 nerves and separating the plane between the sartorius and vastus medialis muscle. Now coming back to the apex of the femoral triangle, 1 to 2 centimeter distal to the apex of the femoral triangle, then the second injection will put just next to the femoral vessel under the VAM, so that while injecting the drug, you can see the compression of the femoral vessel. Now, the effect or analgesic effect of the adductor canal at any level, below at the level of proximal adductor canal, mid adductor canal or distal adductor canal is same. But we recommend to give proximal adductor canal block so as to avoid the proximity towards the surgical area, because this dual subsartorial block we are mainly given for the total knee replacement surgery, and this surgical dressing may come up to this area. So that proximal adductor canal area is quite safer to give this block. Now coming back to the high pack block. High pack block is nothing but the putting high volume into the proximal adductor canal area. Same only, again identify the apex of the femoral triangle, move 1 to 2 centimeter distal, you will enter into the proximal adductor canal area, then around 30 to 40 ml of drug can be injected, first targeting the saphenous nerve, and remaining drug you just have to deposit below vasoadductor membrane next to the femoral artery. So this is high pack block. Now we'll see how IPAC is given. We are tracing the femoral artery. Femoral artery is going away from the sartorius. Now when it moves away from the sartorius and enters into the opening of the adductor magnus, you can see over the anteromedial aspect of the leg, you can see the condyle of the femur is also appearing. So this, the part of the vessel which is entering into the adductor magnus is nothing but the popliteal artery. This femoral artery becomes popliteal artery. So you just have to put one 10 to 15 centimeter needle in plane and deposit drug between the popliteal artery and the condyle of the femur where the capsular attachment of the knee joint is there. So it is just creating a field block between the popliteal artery and the capsule of the knee joint. So this is a popliteal artery, this is a capsule of the knee joint. In plane needle will come here, and while just put the needle here, and while withdrawing just inject around 20 cc of the local anesthetic. So this infiltration or this injection will block only the popliteal plexus and it will cover the posterior component of the plane. Same injection you can give by putting the probe over the popliteal area. So just ask patient to flex the leg and just try to, pointer is towards me. I am scanning over the popliteal region. I just kept my probe over the popliteal crease. I will try to identify the vessels. So I can see the vessels here. So you can see the popliteal artery, which is appearing as an anechoic. Just above the popliteal artery, there will be vein. So upon, you can see the compressibility of the vein. And just above the vein, there is tibial nerve. Typically, we are seeing this picture while giving popliteal sciatic block. If you trace upwards, this tibial and common peroneal nerve are meeting together and they form sciatic nerve. But right now for IPAC block, you just have to keep the probe over the popliteal area. When the tibial nerve is visible, just try to increase the depth so that you can see the hyperechoic portion of the femoral condyle just below the popliteal area, popliteal vessels. So you can see the hyperechoic femoral condyle. So when you see the femoral condyle, you just have to take the needle, around 15 to 20 centimeter needle, and put in plane needle so that the needle will come between the popliteal artery and the hyperechoic bony area of the femur. And while withdrawing the needle, just deposit around 20 cc of the drug, creating a field block. So this is how the popliteal approach of the IPAC is given.
Thank you so much for listening.